Those of you who know me know that this is one of my favorite things to talk about. Sometimes you can't get me to stop talking about this. So when we're talking about passion and maternal health, a lot of this part is actually my passion. So I'm delighted today to get to present with my amazing colleagues on how lactation policy impacts maternal and child health. So I have a question for you guys now that we listened to that systems change talk. And that question is, before you breastfed, if you breastfed or fed your baby, what did you think breastfeeding would be like? Right? Natural, easy. Yep. I watched my mom do it and I was like, I don't need a class for this. You just stick that baby right there and it's great, right? Yeah. I have a video of myself, which one day I will unearth. And it's like the day I gave birth and my baby is wrapped up like a burrito. And I have this huge smile on my face and I'm just like bringing him in the general direction of the breast. And he's like, right? Like, like what is going on? Yeah. That child took a while to learn to breastfeed. Poor kid. And me, right? I thought that this was a natural thing. I would just do it, right? Turns out that's not true. And as we think of systems change, that's one of the pieces, right? The mental models that maybe we should just be able to do it because other mammals do. Well, I've seen those other mammals sword nipples. Have you? Yeah, they've got them. So I wanted to talk today about lactation and how policy in lactation impacts maternal and child health. You switch the slide for me, please, Camille. I have in front of us two absolutely amazing speakers. And their names are Erica Glaze and Biana Billings. Erica is an accomplished health educator and consultant with more than a decade of experience in public health. Her passion for helping people extends to her work with expectant parents. As a childbirth educator and lactation consultant, she counts it a privilege to support parents in preparing for birth and breastfeeding. Erica has a Master of Public Health degree and a certificate in community nutrition. Erica is a Master Certified Health Education Specialist and International Board Certified Lactation Consultant. Erica is an Arizona native and lives in Phoenix with her husband and two sons. Biana started her breastfeeding journey after several years in blood banking and dialysis. She recognized the importance of health education after working with populations that were unaware of the long-term impacts of their health-related decisions. She's a student of the Lactation Consultant Education Program at UCSD and is an IBCLC. She also participates in mentoring groups for minority women in business and is also the founder of Breast for Baby. So I am so excited to have them both here with us today. And one thing that we have in common, besides style, is that we are all IBCLCs, International Board Certified Lactation Consultants. And I've been playing with these slides and I shifted them around a bit when I realized, I don't know if everyone even knows what that is. Who knows what that is? Okay, some of us, right? So along with my colleagues here, we are the highest level of breastfeeding clinician. We have a long path to become certified and we work in lots of different places. And our services are covered by private health insurance as of 2012, right? Next slide, please. We all work in private practice up here, and we see both mom and baby as a dyad and as patients. So we communicate with both mom and baby's providers. We have long visits, frequent visits, and we often see our moms before their postpartum OB visit. In fact, almost always we do. We do lots of work other than helping moms maybe get the baby actually latched, which is a huge piece. But we work with moms to figure out what's going on and birthing parents around low milk supply, oversupply, breast infection, bottle feeding and pumping, metabolic causes of lactation failure, lots of different things, tongue tie, which you probably have heard of. And we do tons of counseling. Next slide, please. So we do all this in large part because there's recommendations that says that people should breastfeed, right? And these recommendations are to 2 years or more, right? With complementary foods and 6 months of exclusive breastfeeding. Next slide, please. And why are they public health recommendations? Because breastfeeding is a normal thing that our bodies expect to do as parents. And as such, when we breastfeed, there are decreased rates of breast and ovarian cancer, heart disease, type 2 diabetes, and interestingly, postpartum depression. And in the child, we already know that their risk of being hospitalized or having respiratory infections or gastroenteritis, you know, those puking things that your kids get when they go to daycare, and that goes down. And asthma. Next slide, please. So we know that in Arizona, 85% of parents start out breastfeeding. Only 58% are still breastfeeding at 6 months. And at 12 months, which is only half of what the World Health Organization now recommends, only 40% are still breastfeeding. So most parents are starting out wanting to breastfeed, but they're not necessarily making it there. Next slide. And we know that 60% of new mothers stop before they want to. And the reasons why: difficulties with lactation, infant nutrition, and weight. Their baby's not gaining weight. They are ill or they need to take a medication, or the effort associated with pumping milk is a lot. These are literally all things lactation consultants help with. Like, this is like literally our call to action. Thank you. We also know that parents with lower incomes and those receiving benefits from WIC have lower rates of breastfeeding initiation, duration, and exclusivity compared with higher income parents. So this is a health equity issue. And in Arizona, if you are insured privately, chances are very good that your insurance plan will cover lactation support outside of the hospital. However, if you have an access managed care plan, chances are basically zero. Because access, unfortunately, in our state does not currently cover breastfeeding support. Some of our low-income parents do receive excellent breastfeeding support from WIC, but I will talk about that in a minute. Next slide. So some of these insurance panels may not credential us, and that's a barrier. And our state Medicaid does not cover breastfeeding and support and counseling. Interestingly, in practice, what we see as a barrier is that when we have parents who have access in our clinics, very few of them report receiving a breast pump from their plan. And because that's 51% of births that are covered by access, that's a heck of a lot of moms and babies that are not getting what they need. And WIC, while it is an amazing and absolutely critical program, it was not ever created to provide breastfeeding support for 51% of a state, right? Yeah. And in several Arizona counties, one contracted IBCLC is responsible for all the WIC participants in that county. Yeah, next slide, please. So if you have private insurance, chances are good you've been receiving ads in the mail your entire pregnancy about where to get a breast pump. And you can go online and put in your thing and they will send it to you before you even have your baby. The confusing thing for those who have access is that it doesn't seem that people know where to get them. And I know that on Navajo Nation, and last year we heard that the Navajo Breastfeeding Coalition does provide some breast pumps, but they were running out of pumps because the hospitals, the parents, and WIC didn't know how to get pumps other than from them. So what we see and what we'll hear is a lot of things that maybe you wouldn't be so excited are happening. That people are borrowing pumps and they are having to go pay out of pocket for something that they should get like everyone else. Next slide, please. So again, private insurance is required to do this. Access plans do actually cover breast pumps, but in practice, it seems like it's not all going there. And it seems to me that that's a systems change issue as well. Next slide. So we know the federal mandates all private insurers provide this breastfeeding support and counseling. And insurance coverage of breastfeeding support reduces dependence and cost of infant formula, reduces parental stress, improves maternal and child health, and reduces anxiety. Next slide. We also know that the report we heard about this morning, the Maternal Mental Health Advisory Committee made recommendations that access separately reimburse lactation consultants for breastfeeding support and counseling using a state plan amendment. Turn the slide now. We also know 14 states have state plan amendments to do this. So we would not be the first, we would not be the last, but this is a step we want to take. So that's kind of setting the stage for those of you who don't know yet what's going on here. But I want to talk about how things play out in the real world. And that's why I've brought my colleagues Erica and Biana here today. So I'm going to start with a question for you both. And I'm going to bring my microphone over there so I can sit with you because I feel sort of weird to be over here. Yes.
Okay, so before we start, we're actually going to read a parent story. This is a parent who gave birth this year. It's a Black mother who has access and is also a WIC participant. And we spoke to her about getting lactation support in the hospital and then her challenges or barriers accessing a pump after she returned home. Next slide, please. My experience receiving lactation care in the hospital was flawed. After I delivered my baby girl, I was having trouble breastfeeding her. It was very painful and she wasn't latching on properly. So when I would ask for assistance, the nurse only suggested giving her formula. Even when speaking to the lactation nurse, she too suggested formula and trying different positions. As a new mom, and this being my first experience, I didn't know what to expect. The day I was discharged, my doctor/midwife informed me that the nurses did not fully give the care that they were supposed to. Next slide. So this mother, just remember, she does have access. I did not have any challenges with receiving a pump, but the breast pump ended up not working. This was through my insurance. WIC never gave me one, so I've been using the hands-free one. It became a phone tag situation with the WIC office. Someone was supposed to get back to me, but never did. So we wanted to just uplift her story because Biana and I see this happening a lot where we are called in to kind of help moms who are literally just out there trying to figure it out on their own. They didn't get the support in the hospital, and then now they're out and they're in the community and they're still not getting the support that they need either.
Okay, so I have a question for you both. Thanks for that story. Could you talk a little bit about the health disparity involved in this lack of coverage?
Sure, I can start. So I think one of the things is starting and looking back at the hospital, I think about this mom's story. When we look at data, we see that particularly our Black infants and Black mothers, they're way more likely to be offered formula in the hospital setting than white mothers and white infants. And so they're already starting out right at this disadvantage. We're not giving them the support, we're pushing formula. And so we don't even see them getting those long-term benefits of breastfeeding exclusively because we're just pushing what's convenient in that moment for them instead of giving them the support that they actually need. I think the other issue too is when we talk about getting access to pumps, sometimes I think when we hear like breast pump, we think, oh, it's just one of those lactation things. Not everybody needs it. But breast pumps are medical devices. These are medical devices regulated by the FDA. So not getting a family the medical device that need creates disparities. It increases our healthcare costs if we're pushing formula when that parent really wants to breastfeed. And of course, none of us are anti-formula. We know that parents combo feed, there's a place for it. But when parents really want to provide human milk for their baby and they know the benefits of it, we should be there to support them.
Those are good points, Erica. I think the biggest consideration is the effect on the family if a parent is trying to feed their baby and cannot. You feel like a failure from the baby's first day of life. And most of these families are seeking help. They're asking for information. They're going to the pediatrician. And if lactation visits aren't covered, all they're getting is a weight check. So come back in 2 days, baby's weight should be up. Come back in 2 days, baby's weight should be up. I had a mom yesterday who had 4 weight checks. No one ever sized her for flanges. Nobody told her to pump. So even though we got the ball rolling at day 7, baby was on formula. She cried every time she fed the baby with formula. And her supply is going to be affected by that. Poor milk removal is going to result in a lower milk supply despite all the efforts. And not having the right size flanges is also going to cause an issue. So people are going out and they're buying wireless pumps so they can pump every 2 hours, but they're buying a $25 pump off of Amazon because that's all they can afford. And a $25 pump isn't going to get the job done.
Thanks for that. Could you talk about the long-term impacts of these barriers to access to care for mothers and children?
I think we kind of touched on that a little bit, but I also think about the mental health aspect too. A lot of these parents, they're in that postpartum period and we're adding another barrier, right? Trying to feed their little one, trying to make sure they have access to a pump, making sure they have access to lactation care too, trying to also care for themselves and recover. The mental load on those families is really, really difficult. And so that's one of those long-term impacts. If they are growing up in an environment where there is that toxic stress, and we know being under that for so long causes those long-term health effects for not just the parent, but also the other children in the household too.
My biggest reason that I encourage breastfeeding, chest feeding is the long-term development. This is my nerdy thing that I always talk about with every family, that this is the most important choice that you'll ever make for your child. When babies feed at the breast, they develop their jaw, they develop their airway, they develop their palate, they learn to suck, swallow, breathe, they help with their digestion. If the tongue doesn't move functionally, the rest of the body does not follow the functional pathway that it's supposed to. So it's important that in helping them guide these choices that we set this child up for the rest of their life. In addition to that, these families that do not have access to breastfeeding, chest feeding bottles are given formula bottles. And on day 2 of life, we're already offering this baby 2 ounces of milk. In a bottle nipple, that's a size 2 or 3. That's faster than anything that they should be able to accommodate. And we stretch their stomachs and we get them into dysfunctional breathing patterns right away. They carry that the rest of your life. If you never learn to breathe, you do it the rest of your life. How many people in here are mouth breathers? How many people snore, right? And that's something that's functional that starts foundationally at the breast.
Thank you for that. What barriers have you seen your clients face in accessing breastfeeding support?
So typically for our private insurance families, they can go through like Lactation Network or somewhere to get their visits covered. But we often see our families who have access insurance, they cannot afford to come see us. They can't afford our cash rate. So we have to lower our rates. I can speak for all of us up here. We lower our rates significantly to the point where it's like, we really didn't make anything from that visit, but we do it because we know that this family needs our care. And we're here to support them, but we shouldn't, as professionals, have to go without or not get reimbursed because we want to be here for our community, right? It should be where we are valued for the work that we do, insurance pays us for that, and then families get the access and the care that they need. The other issue is for our families who may not have private insurance, but they may not qualify for access in WIC, and then they're trying to figure out also, how am I gonna pay cash to come see a lactation consultant? So I think a lot of times the barrier is the funds to do it. Either they have it or they don't have insurance and they can't come and see us.
I think the biggest barrier is time. Who has the time to do all these other things? And I have to keep this baby alive. I have to feed him every 2 hours. I'm so tired. I don't even know if I ate today. And then you want me to go drive to this place and get this and call this person, go call the pediatrician and ask if he can send me a referral. Can I get a prescription for a pump? Is this place going to give me a pump today, or do I have to come back and prove that that we're not doing well? Do I have to say the right things? I don't even remember what you told me to say in order to get a pump, to express the need for a pump. So there's a huge mental load. There's a financial load of driving up and down the road and trying to get things. And then there's a cost effect. There's a cost with that as well. I have a family friend who didn't know to come to me, and they were buying breast milk because they knew that they didn't want their baby to have formula, and they were paying $2 an ounce. So it got costly really quickly.
Yeah, yeah. So I want to talk about how we pivot and work around and play and try to figure out how to manage this health disparity in our community. So I know that you both are very creative, and so I'm curious to hear about what workarounds you as a provider have used to try to navigate the lack of support, the lack of breast pumps for these mamas.
We do everything. We spend a lot of time and energy, weekends, nights, we're never off, right? Because somebody somewhere needs something. So we support people in getting pumps from other people in the community. We crowdsource breast pumps, and we will get new tubes and things for it. I'll buy things myself if I'm out in the world and I'm like, oh, this is on sale. I know somebody's gonna need it. We refer moms to other moms to get donor milk. If we have a can of formula that someone tried one time and they know it didn't work for their baby, I know a mom that needs that. Can you get in contact with her? Can I give you her information with her permission, and you give the formula to this person? So we use a lot of energy trying to keep the community cycles going so we can get resources to each other.
Yeah, I would agree with that. I'm not one to turn down any breastfeeding like donations. So I always bring them to the office. We have a little area in our corner where we have just bottles and tubes and whatever, because I know eventually some mom is going to probably call and need it. And so that's what we do. We go out into the community and try to get that mom the care that she needs. I'll often ask that mom, like, do you know any friends or family who recently breastfed? Maybe they don't need their pump anymore. Let's see if we can reach out to them to see if you can use it. I think the hard thing too is sometimes when we do get donations, making sure that that pump is still quality and still good. So we spend time testing pumps, making sure the suction is good, because what we don't want to do is give a mom a pump that now doesn't work for her either. And so that's the other part, making sure we have pumps that actually work and fit that parent that needs it.
Yeah, thanks for that. What mental health load do you think the lack of insurance covered breastfeeding support causes for parents?
Yes.
There's a load. It's heavy. We see it. I sometimes feel like we're counselors, like we're just there to listen sometimes. We've had parents come in and we haven't even started the visit and they're in tears, or they're just, everything's overflowing. Like Jenny said, we usually see parents before they've seen their OB. So there's a lot of emotions that come with just the postpartum period. There's a lot of emotions that come with feeding. And there's a lot of emotions around like doing it the right way. Like, I want to be successful, and this is the way that it needs to happen. And if it doesn't happen that way, a lot of our families feel like they have failed. And so a lot of times for us, it's reassuring them that we're going to walk alongside you no matter what lactation looks like. If it's a lot of human milk, if it's donated milk, if it's a combination, we're there to support you. But we do find ourselves a lot of times sitting there listening and being a counselor and then getting to lactation when it's appropriate. Thankfully, we're there for like an hour or two, so we have time to let all of those emotions come up too.
And we do refer to services, and we do it a lot. But then if you can't afford milk, and you don't have the money to drive from one side of town to the other, can you afford to drive to a therapist? Or do you have to see someone with sliding scale? Like, we refer to outside providers, but there's so very few that take access for mental health services. So that's also a challenge.
Yeah, thanks for that. You know, as we talk about the mental load of this, I can tell you that I'm lucky right now. I don't have to take phone calls for the breastfeeding center. But when I do, it's almost, I don't know, a third of the calls are a mom who calls and we're working to get her scheduled, and then she has an access plan. And we have, I feel like, a pretty low cost visit, but much of the time it's too much, right? Like, oh gosh, I thought my insurance covered it. And I, as the provider, have to be the one to break it to them that their insurance doesn't cover it. I give them the phone number to WIC and hope that I send them to the right one, right? Hope that the right person answers. And sometimes they do, and sometimes they get great support. But I'll tell you, oftentimes they call me back 2, 3, or 4 days later, and they're like, hey, you know, I didn't get what I needed. Can I just come in? I figured it out. I guess I can pay for it. And, you know, as a provider, I'm over here going like, oh my gosh, like, right? I don't want to charge someone who clearly can't afford something. But at the same time, you know, there's not very many of us. We, you know, there's not thousands of lactation consultants, and we still have to pay rent on our, you know, offices. We have to pay for recertification. And, you know, so we do need to charge something for our services. But I think this goes back to the unpaid labor, the unpaid labor force of women, right? And it's not just lactation consultants. Thankfully, doulas are going to now be covered, which we're going to talk about soon. But it's again, just this, I don't know, feeling that maybe women should figure it out on their own. And it's not that there aren't people who care and don't want to change it, because Rachel, I know you want to change this more than anything. It's that for some reason it was overlooked, right? And why is it that women's healthcare was overlooked, right? Healthcare that directly impacts our children and our bodies and our ability to be in the world. I think that's the piece that gets me always about this.
There is one saving grace. The state of Arizona has a warm line, a breastfeeding hotline, if you all aren't aware of that, and you can direct them there. Renee Pelting is the one that runs it. She is a brilliant source. She knows everything about everything. She can tell them where to go, where to get services. And sometimes people just call because they want to talk to somebody. It's a 24-hour hotline. So that is a good resource if you don't know where to send the people that need support.
Anything else you'd like to share before we move to questions? Yeah, some of you may have noticed that Erica's little guy, Judah, is maybe not in this room right now.
He's somewhere. He's in the hallway with the mom.
She's currently a lactation consultant, which is a very distinguished.
It comes in handy because I'm like, with my patients, I'm like, I get it. If I text you back at 3 a.m., I'm up too.
Yeah. So you guys have any questions for this panel? Yeah.
For women that are on MOUD, medication for opioid use disorder, ACOG, NIH, all of our leading authorities say it is fine to breastfeed while on MOUD. We get as professionals for a variety of types of services, whether it's child welfare or home visitors, whoever. So you can't breastfeed because you're on methadone, buprenorphine, what have you. Do you run into that myth much with families you work with, or maybe other myths? That's just misinformation
We see more patients coming from hospitals for minor surgeries, things like that, saying my doctor says I have to pump and dump times X many. There's enough literature to say that, okay, my doctor who prescribed me the medication said that it's still safe to breastfeed. So I don't see that very often. And I've helped quite a few people and they know they're still breastfeeding with no issues. But it's epidurals or you had to go back in for a surgery post-delivery, things like that. Mastitis, they'll tell them to pump and dump, but we don't really see that as often.
Yeah, I would like to comment on that actually, because, and yes, after that, Lindsay. So I was actually unaware of this issue because, you know, in my lactation education, I learned it was totally fine and it was great. And that's what we want to do. And then I had a grandma call me who was at the hospital with her daughter who was on MAT treatment. And she was in tears and she said they won't let her breastfeed. She has a plan. She's got everything written out, everything that we're supposed to have. And this was several years ago. And they won't let her breastfeed. And I was like crying with the grandma on the phone. And I'm like, you're right. It's totally okay. And it's the best thing that they should do. And you should totally send them. I was sending her paper after paper after paper. I don't think that mom got to breastfeed that baby in the hospital. It just didn't happen. And how sad that we have all this information saying it's actually better for that child to breastfeed. And yet, because of our preconceived notions and the stigma, right? We assume that it's better for that kid to be taken away from their mom, essentially. I actually had an undergraduate student who wrote her honors thesis on this, and what she did was she surveyed the neonatal and obstetric nurses through their organization about their beliefs and knowledge about opioid use disorder and breastfeeding. And what she found was almost none of them believed that those moms should keep their babies, unfortunately. Almost none of them believed that they should breastfeed, and they did not agree with the policies. So I don't know if we've changed a lot. I can hope we have, but it is shocking, yeah.
That is an instance where you call the breastfeeding hotline from inside of the hospital and put them on the phone with the doctor.
And Lindsay?
Well, I have a lot to say about that.
Yeah, let's make sure we get you a mic too. Does she have a mic back there? Okay.
So working now, okay. Yep. So first of all, I will echo the issues with getting the pumps, because that's when we're working with our moms ahead of time. We know there's probably going to be those issues in the hospital. So we really try ahead of time to get our moms to get their pumps from Access. And they give up a lot because I end up taking over and helping them call. And I'll get them pumps, and sometimes they'll wait till it's too late. And then literally we'll have the pump, it'll be local, and they'll want to ship it so that it'll take a few more days. And I'm like, I'll literally come pick it up for them. Please just let me come pick it up. So we've had those issues, but I also try to set that up because I know they're going to have trouble when they get into the hospital. But I thought it was just the biases of the nurses and misinformation. It's actually banner policy that if they're on MAT, that they cannot breastfeed. And so, or they cannot provide support in the hospital. So that's why I try to get them ahead of time to have their pump and to give them their information and that kind of stuff so that we can support them. Of course, we try to transfer them to Jacob's Hope within right at 24 hours so then we can take over. But then I will say we have a group of wonderful lactation consultants that donate their time to come in and help us support the breastfeeding at Jacob's Hope, but then they leave us, and as you see, then they don't have the support in the community. So we do what we can, over the phone, and same thing, we use the 24, the hotline and all the things, but it's definitely a work in progress, but it's beautiful when it happens because the babies do so much better. So.
Thank you for that, Lindsay. That's super helpful. You have another one?
Yeah, there was a question that came up in the chat, and they want to know if the mom is on Access, does she not automatically qualify for WIC, and where would she get a pump?
She automatically qualifies for WIC. She can get a pump. The challenge is there's been ebbs and flows over the last 2 years, I would say. Post-COVID, I used to be able to send someone in pre-COVID and you can get a pump same day. It wasn't an issue. I have gone to WIC myself because the person couldn't pick up the pump. I picked it up for them and delivered it to them. I've met somebody at Mountain Park WIC. I've met somebody there to help them with that. But there's been more challenges with picking up the phone and calling and saying, hey, I have someone here in my office. Can we talk? Can we get them a pump? I can't talk to you. Okay, I'm the lactation consultant. I just want to know if I have to send a prescription. Do I have to do anything? No, we can't talk to you. Okay, here's the patient. Then they talk to the patient and they're like, well, if you're combo feeding and you're not exclusively feeding, then we can't get you a pump. And I'm like, but I'm here right now in the office with this person telling you that we desperately need to move this milk so we can build supply. So the challenge is knowing the right things to say to get the pump. I don't know what's happening in this part of Arizona where we're having challenges, but I can say that none of my access moms have I been able to get a pump in the last 2 years. 0. And I called the other day. I called the other day for a first-time mom who did not have a pump, didn't even have a backpack to carry her stuff around in. And I said, we're gonna do this now. So I asked for her card. I looked at the number on the back of the card. And then I called and I got transferred 7 times. And we spent 45 minutes and then my appointment time was up and I had to send her on her way. And she said, I'll call. And I told her which WIC to call. And we still never got a pump. I saw her yesterday. She still doesn't have a pump.
Yeah, back. I need a mic.
Who at the legislature do we need to talk to? Who at the legislature do we need to talk to?
Oh, I noticed Sarah Liguri was here earlier. She'd be a good one. Sarah Liguri, yes. You know, this is the policy that we are addressing next in our Arizona Maternal Health Policy Coalition, because it's just so crazy and it'd be wrong, right? Like, it doesn't seem like it should be the case. I feel like every time I talk about this, people are like, what? Are you kidding me? And it just is. And why the Affordable Care Act did not pull Medicaid along with it, I will never understand, because I feel like that would have solved some stuff too. But again, this is a systems barrier, right? It's on both ends. It's like we've got the policies up here and then we've got the mental models down here where, like, of course, everybody should be able to get it. And so if you don't even know that people can't get it, and if you think breastfeeding is easy, well, then why would we need to enact it? Why would we need to do that? Thanks, Selena. It looks like our time's up. So, plug for the Policy Coalition. If you're interested in being part of this solution, join the Policy Coalition and talk to your legislators. We're going to get a whole new crop of them. So let's do it. Okay. Thank you so much. And thank you to our amazing panelists that I get to call friends.